Hi, I'm Sunit Mittal, Chair of the Cardiovascular Service Line at Valley Hospital, and today I'm joined by Raj Tayal, Director of the Cardiac Catheterization Laboratory, and Mitul Patel, attending in vascular surgery. And we're here to talk about pulmonary embolism and the Pulmonary Embolism Response Team that we've created at Valley. Mitul, maybe I'll start with you. You've had a long history in pulmonary embolism.
Sure.
Maybe you could start off with just telling us, how big is the issue of pulmonary embolism, and why did we feel the need to have a dedicated Pulmonary Embolism Response Team, or PERT, at Valley?
So what we're seeing is there's about 650,000 cases of PE a year that get admitted, and it's the third leading cause of in-hospital death from a cardiovascular complication. So what we were seeing is there was a lot of patients coming to Valley Hospital, and we were getting a treatment algorithm that wasn't quite consistent. So one of the things that we noticed was that by offering an intervention, we were able to rescue people with a procedure that was causing less complications. So once we started the program, we were noticing that patients were being strategized into different treatment modalities depending on who was on call. So we felt that to standardize the program, we created a PERT team so that patients that come to Valley all get the same access to the level of care that we should provide.
Great. And Raj, I'm assuming that the standard therapies are some sort of anticoagulation with heparin, maybe even thrombolytic drugs. Can you describe, what these standard therapies are and how the interventional approach works and is different from those?
Right. So, the standard of care typically used to be the administration of anticoagulation, just like you had alluded to, predominantly involving the use of heparin-based products or Lovenox, which would then be transitioned to an oral anticoagulant for an extended period of time. On some cases where patients were presented and they were acutely ill, they would be administered thrombolytics, which, as we all know, have a high risk of bleeding complications. In lieu of that, what we started doing was actually entering the pulmonary arteries and aspirating the thrombus out manually using different catheter-based techniques. And as a result, we were able to forego the use of thrombolytics and decrease the amount of anticoagulation that was required. As a result of that, what we've done is been able to decrease the length of hospitalization and the long-term complications associated with pulmonary embolisms.
Great. And so, Mitul, you spoke about the need for homogenizing variable care. I think as physicians, we know whenever there's a lot of variability in care, that's when bad outcomes occur. And so I'm assuming that the PERT team is a way to kind of homogenize the care for the better in these patients. So maybe can you, review a little bit about how the practitioner who's presented with a patient with pulmonary embolism decides whether the PERT team is appropriate for that patient?
Sure. So the first thing we did is we created a pathway to stratify our patients. So one of the things that we decided was that if there's an algorithm and there's a standard approach to managing our patients, we're going to create consistent care. So we decided that we should stratify the patients based on a low risk, moderate risk, and a high risk. And the way we stratify these patients is based on clinical presentation, lab markers, and also diagnostic data. So we created an algorithm where if they have evidence of RV or right heart strain, dysfunction either on the CAT scan or an echo, and also elevated biomarkers, and those are the patients that we would consider for an intervention. So by stratifying our patients, we allowed our ER and our pulmonary doctors to better identify the patients, and then we kind of, through education, have instructed them that if there's a moderate risk or a high risk patient, get the PE team involved so we could evaluate the patient to decide is an intervention necessary.
So it sounds like clinical presentation, biomarkers, echo, and CT imaging are some of the core diagnostic tests that help us determine, which is the risk category for the patient.
Absolutely.
Yeah. So Raj, anytime, we think about these approaches, it's critical that they be a 24/7, 365 approach. How did the interventional and vascular surgery programs at Valley work together to ensure that we had, 24/7, 365 coverage of high-risk patients with an interventional approach?
So what we've done is we've created kind of an alternating schedule. So we split the call 50-50. So one of the members from the team is always available. We have a text communication chain, which is obviously HIPAA secure.
Great. I think, team-based care is so important these days. It's very hard to operate in a silo. I think this is a perfect example of how, bringing people in with the expertise as a singular team can improve outcomes. Mitul, you've been very passionate about this area for a long time, and of course one of the areas is clinical research, and there's a lot of great clinical trials occurring in pulmonary embolism treatment. Can you talk a little bit about what are some of the things on the horizon and how Valley's participating in some of those clinical trials?
We've partnered with clinical companies to participate in clinical trials. We were involved in a FLASH trial, which looked at moderate to high-risk patients and the effectiveness of mechanical thrombectomy. And most recently, we've become the only site in New Jersey to be involved in the PEERLESS 2 trial, which is they've taken moderate-risk patients, we're randomizing them into either anticoagulation alone or mechanical thrombectomy, and we're going to check outcomes at 3-month follow-up, 6-month follow-up, and 1-year follow-up to help kind of identify the patients and really see the effectiveness of the thrombectomy model and show that it is what we should be doing to our patients.
That's fantastic. And now, obviously there are many pulmonary embolisms that present at Valley and in the community as abroad. Can you summarize a little bit about how a practitioner would reach out to one of you, whether they were practicing at Valley or maybe at an adjacent hospital, who could use services or an evaluation for whether such an approach is appropriate in a patient?
So I think at Valley, it's pretty obvious. There's a PERT schedule. On the schedule, it's distributed to the ER, to the critical care team, and that's how they contact us at the hospital. Also, our cell phones are readily available to most of the community. So generally what happens from other facilities is that if we're on call or available, they just call us, and then we have worked with the ER here to really facilitate ER to ER transfers. So if we get a phone call for a patient that has a PE, they're concerned that there's some RV strain or dysfunction, and they feel that the patient would benefit from a higher level of care, it just takes a quick phone call, and the ER will outreach and facilitate the transfer.
Fantastic. What is the thing you're most excited about as you look forward in the next couple of years in pulmonary embolism management, or is there anything else you would like to leave the audience with today?
I think for me, it's just the clinical trials that are ongoing and the data that's going to support the work that we've done the last 4 to 5 years to really bring the standard of care up to what we've been offering here at Valley.
I think one of the most impressive things about the program is just by word of mouth and kind of clinical outcomes, what we've seen this year is over a 50% increase in the overall volumes. So I think as people are becoming more aware of the therapies that we're employing, they understand that these are relatively low-risk interventions with very big clinical impacts. We're starting to see more and more referrals, and our program has doubled in size as a result of that.
Yeah, and I think it's important to note that the number of patients with pulmonary embolism hasn't doubled or increased by 50%. It's just that now we're recognizing the patients and giving them appropriate therapy, and we're really excited now that we are able to hopefully offer every appropriate patient this option. Well, I want to thank Raj and Mitul for spending a few minutes today. I think it's really exciting to see the evolution of the PERT program at Valley. It really heralds a new era of pulmonary embolism management, and look forward to the new clinical and academic science to support these therapies in the years ahead.